Hello, everyone, and welcome to this week's It's Worth a Shot. Our presentation topic today is hepatitis, since May is Hepatitis Awareness Month. I am Marcy Gallagher, and will be your moderator today. Next slide, Mary. Just to review our standard disclaimer, this presentation may contain information and our content supplied by third parties. The information provided does not constitute endorsement or recommendation by Mountain Pacific. Next slide. So this week, May 12th through May 18th, we'd like to give a special recognition to hospitals and skilled nursing facilities as we celebrate National Hospital Week and National Skilled Nursing Care Week. So thanks to all of you and what you do on a daily basis to care for our patients and residents. I really like this year's National Skilled Nursing Care Week theme, Radiant Memories, a tribute to the golden age of radio, embraces a time when the airwaves resonated with captivating stories and melodies. More than nostalgia, Radiant Memories is a call to honor the enduring legacy of skilled nursing care centers. So hopefully you're planning something fun in your facilities this week. Let us know in chat if you have anything special planned. Next slide. For our updates and reminders this week, we wanted to share with you for America's Drug Diversion A to Z Guide. I will go ahead and pop that link into chat. And please note that the CMS Skilled Nursing Facility Long-Term Care Open Door Forum scheduled for May 16th has been canceled. The registration page has been updated, and the next Open Door Forum is scheduled June 13th. Next slide, Mary. As always, please let us know if you have any topics of interest you'd like us to cover on It's Worth a Shot. You can post your ideas in the chat or use the evaluation to share your thoughts and comments. We encourage you to complete that evaluation as we do value your input and feedback. So that brings us to our polling question for today. So today's polling question: has anyone utilized the Center of Excellence for Behavioral Health in Nursing Homes to request assistance for a behavioral health consult? So the Center of Excellence for Behavioral Health in Nursing Facilities provides mental health and substance use evidence-based training, customized technical assistance, and resources to certified Medicare and Medicaid facilities that care for residents with a variety of behavioral health conditions at no cost. So you go onto their webpage to request assistance and complete an online form. So we will drop that link into chat, but just curious if anybody has utilized that system. And it looks like most have not. So like I said, I'll drop that link in chat and you can take a look. All right, thanks, Mary. We can close the polling. So typically at this point in the presentation, we would show a slide that displays weekly COVID information. However, effective May 1st, hospitals are no longer required to report COVID-19 hospital data in NHSN. So the reporting into NHSN is now voluntary. So if you have questions regarding state-specific reporting requirements, we encourage you to please contact your State Department of Health or your HAI coordinators for assistance. So this would be folks like Erica Baldry in Montana, Rebecca or Clayton in Alaska, Lucy in Wyoming, and Vila in Hawaii. So at this time, it's my pleasure to welcome Helen McCaffrey, who is the HIV and Hepatitis C epidemiologist with the Montana Department of Public Health and Human Services Communicable Disease and Epidemiology section. Helen received her graduate degree from the University of Michigan in 1994, and as a longtime state employee, Helen has worked in STD, HIV prevention, and women's health programs. For the past 8 years, she has been monitoring and reporting data related to HIV and viral hepatitis across Montana while working closely with local health departments and their partners on disease surveillance, investigation, and control. Helen will be providing some Montana-specific data, but her presentation contains lots of good information applicable to everyone. So welcome, Helen. Thank you so much for joining us today, and I'll turn the presentation over to you.
Okay, thank you. I'm going to do a volume check. Can you hear me okay?
Sound good.
Okay, perfect. Well, thanks for that welcome. I really am excited to be here and present on hepatitis in Montana. It's really a subject area that I'm very interested in and passionate about. So we can just go ahead and get started, and we'll have some time to talk. And at the end, we'll have some time for questions as well. Next slide. What we'll talk about today are some trends in viral hepatitis, demographics, particularly of new diagnoses, treatment, and then stigma related to viral hepatitis. Next slide. Just a few notes when we're discussing hepatitis C, we're using both probable and confirmed cases. When we talk about hepatitis A and B, we'll just be talking about confirmed cases. As a low morbidity state with small number of events should be interpreted with caution. And because of that, at times, I'll be using a 5-year aggregate to discuss number of cases. And then 2023 data is provisional. This time, we have not closed out that data set just yet. Next slide. I want to talk briefly about the impact of COVID on hepatitis C related labs. So this is showing the number of hepatitis C related labs reported to DPHHS, and we use that as a proxy for hepatitis C care because we don't get electronic healthcare records. Oftentimes we'll use labs to see, okay, who's coming in for hepatitis C testing, whether it's diagnostic or monitoring. So you'll see in 2019, had almost 13,000 labs. Now these aren't patients, but these are labs come in to us. 2020, when we had COVID, that decreased quite a bit. People may have been interrupted with their healthcare usage. We might not have had the screening events that they had before. And while it has gone up each year, we still are not at pre-pandemic levels. Next slide, please. So we'll talk about hepatitis A. So hepatitis A, we have a low number of confirmed cases. So we're very low morbidity in Montana. We'll see that the increase of cases in 2019 was related to an outbreak, primarily among injecting drug users and homeless populations. However, there is a vaccination for hepatitis A. Next slide, please. So moving along to hepatitis B. So these modes of transmission are more similar to hepatitis C: sexual or injecting drug use, close contact with an infectious person. There's perinatal transmission. Like hepatitis A, we have a low number of confirmed cases. So really we see sporadic cases for viral hepatitis B, and vaccines are available. Next slide, please. So I'll move on to hepatitis C. And one reason I focus on hepatitis C for most of the presentation really is it's because it is the third most reported disease in Montana, behind COVID and then chlamydia. It's a bloodborne pathogen, and unlike other types of viral hepatitis, there is no vaccine or post-exposure prophylaxis. Next slide, please. This is the disease progression of hepatitis. So you'll see on the right-hand side, 100 people that were infected with hepatitis C, 55 to 85% developed chronic hepatitis. 20 to 30 of those 100 people will develop cirrhosis, And then about 1 to 4% developed hepatocellular carcinoma, slightly a few more developed end-stage liver disease. However, the natural history of hepatitis C is not precisely defined because of the lack of prospective studies. And we can't tell the rate of fibrosis progression in the individual. It cannot be predicted early on in the infection. However, there are factors that have been shown to influence disease progression. So someone that is acquisition of hepatitis C at an older age, increased age independent of duration of infection, males, heavy alcohol use, co-infection with HIV and hepatitis B, excess fat accumulating in the liver, or insulin resistance. Next slide, please. We have 2 types of hepatitis C. We have acute and chronic. So acute hepatitis C occurs within the first 6 months after exposure to hepatitis C virus. We have very low numbers of acute hepatitis C reported annually, but really this is because up to 80% of people with acute hep C do not present with symptoms at the time of diagnosis, so it's very underdiagnosed. Between 15 and 45% will spontaneously clear the infection. Next slide. So after 6 months, we consider it a chronic hepatitis C case. We have more of those reported, a little over 1,000 reported annually. It's a 5-year average. But again, people with chronic hepatitis C frequently have no symptoms and don't feel sick. So it's underdiagnosed. There's an estimation that between 13 and 15,000 people are living with hepatitis C in Montana. And when symptoms appear, they can often be a sign of advanced liver disease. So that's why screening is so important. Next slide, please. So let's look at awareness of hepatitis C infection. So the most recent data, and this is national data, estimated that only 56% of people were aware of their hepatitis C infection status. And it hasn't improved very much from when it was last measured, 2001 to 2008, it was just 50%. So a large number of people aren't aware they're infected with hepatitis C. And that awareness is lower in persons who are foreign born or in persons with income below the poverty level. And this might be due to access to healthcare. Again, this highlights the importance of screening, whether people are symptomatic or not. Next slide, please. So I'm going to delve into a little bit of ages and then looking at case status, chronic and acute hepatitis C. So the blue bars are showing the rate of hepatitis C. And again, it decreased from COVID. Now, this doesn't mean fewer people had hepatitis C. You remember for the previous slide, labs decreased as well. It still has not rebounded to pre-pandemic level. We believe this might be influenced by disruption of healthcare usage, reduced community screening events, increase in substance use. So looking at that substance use, the green bar, the green line is the rates of acute hepatitis C. Now, this did something quite different than chronic hepatitis C. Those rates increased greatly between 2020 and 2022. It has been shown that during the pandemic and from years after the pandemic, the rates of substance use have gone up. And we see this nationally, and we have seen this in Montana. So this is likely part of the reason it has increased. Now we're seeing that decrease in 2023. We'll monitor that to see if the resumption of screening efforts has some impact. Next slide. Oh, now we look at age. So chronic hep C by age. This is Montana, 2023. And you'll see in the past, we saw the burden of hepatitis C in an older population. And that has changed. It's dramatically changed. where now we're seeing it in a younger population. So we're seeing the transition of a baby boomer disease to a disease in younger folks. Next slide, please. So I'm separating out acute versus chronic hepatitis C. And we'll just walk through this slide. So the green bars are acute hepatitis C. And you can see that it is even more weighted towards a younger population. 37% are younger than 30, and 77% are younger than 40 with acute hepatitis C. This is becoming a younger person's disease. Whereas chronic, while it has started to trend younger, nearly to the degree that we see acute hepatitis C. Next slide, please. So testing recommendations. 2020, the recommendations changed. We used to focus on routine screening of adults born between 1945 and 1965. Now they recommend Hep C screening at least once in a lifetime for all adults aged 18 and older, and for all pregnant women during each pregnancy. And they broaden these testing recommendations for a couple reasons. One, there are very few symptoms of folks who are infected with hepatitis C. We're seeing it in a younger population because the baby boomers are aging out, and really the primary way people got hepatitis C was from blood products that were not being screened. So they started screening the blood products, and now it's very much linked to substance use, and particularly injecting drug use in the younger population. Next slide. There's additional testing recommendations. And so this is hepatitis C testing regardless of age or setting, and we're really breaking it down to specific conditions or exposures. You'll see people with HIV, people who've been injecting drugs at any time, so not even if they're currently injecting drugs, but if a history, people with selective medication, like hemodialysis, transfusions, organ transplant recipients, healthcare personnel with needle stick injuries or mucosal exposure to hepatitis C positive blood, or children born to mothers with hepatitis C infection. Next slide. So how did we look? How are we doing in Montana? So in 2022, DPHHS did a needs assessment of Montana healthcare providers and interviewed 63 healthcare providers. And you can see that people are primarily screening regarding in response to risk factors. So the first two, people inject drugs, people with signs and symptoms of hepatitis. Next slide. So here are the categories that we talked about in some testing recommendations. All adults over age 18 at least once. 67% of providers say they routinely screen adults over age 18. And pregnant women, they routinely screen 44% of pregnant women. So we have a ways to go for that broad hepatitis C screening. Very much providers are looking at specific risk factors. Interestingly, almost 80% say, I'll screen with people with signs and symptoms, but we know that very few people have signs and symptoms of hepatitis C. So that's not very predictive category for folks who may have hepatitis C. Next slide. So we took a look at Montana Medicaid recipients, and we looked at claims data. What we wanted to see is, of pregnant women by year, how many had claims for hepatitis C testing. So really, we could do better. There's areas for improvement. So of the women covered by Medicaid, we have the number of births on the right, and then the percent screened for hepatitis C. And it ranged from 20% in 2020 to 20% in 2022. So really statistically no difference. Next slide. So when we looked at the US, they're doing slightly better than we are in Montana, ranging from 19% in 2020. They only have 2021 data. They do not have 2022, but it had increased to 26.8. Next slide. So I'm going to move to talking just a little bit about treatment before getting into stigma. So hepatitis C is treated using direct-acting antiviral tablets. It is always needed for chronic hepatitis C. Now, if someone has acute hepatitis C, because of the percent of folks who will clear it spontaneously, folks who have acute hepatitis C generally aren't treated. They really are waiting to see if it develops into a chronic illness. Medications taken for 8 to 12 weeks. So it's different than medication that historically have been used, which was, I think, a much longer duration. It's highly effective. So over 95% of people treated clear the infection. And nearly all people who are successfully treated have sustained virologic response, which is a cure. So next slide. However, even though we have this effective treatment, number of adults cured of hep C in the United States is low. So we can see over on the left, only 1 in 3 are cured overall. But when you look at insurance and age, and then age and insurance, the number and percent of folks who are treated becomes smaller each time. So 1 in 4 are cured of folks who don't have health insurance. 1 in 4 if you're under the age of 40. But then if you're under the age of 40 and with no health insurance, only 1 in 6 are cured. So again, we have a long way to go. So similar to people who are screened for hepatitis C, folks that are diagnosed and cured of hepatitis C is pretty low. Next slide. So we looked at Montana healthcare providers. That's that needs assessment I described earlier. And we were curious about the barriers to treatment. So if treatment is low, what are some of the barriers to that? Just to dive deeper into that statistic. And what the healthcare providers said is they have limited training and experience with hepatitis C medications. So really almost 2/3 of folks just said, I don't have the experience or training. Underneath that, the providers had concerns about their patients, from whether they can afford treatment and medication. And hepatitis C treatment is pretty expensive, and certainly without health insurance. They have concerns about patient compliance, and then concerns about compliance due to side effects, long-term duration of the treatment. So there is a little bit of misunderstanding of how long the treatment is. So some providers probably need a little more training in terms about the new treatment. It is not as long as it had been in the past. Counseling and support, distance folks travel, but really the training and then concerns about the patients were the biggest barriers. Next slide. So I move on to hepatitis C and stigma. And we really see the stigma in 3 areas: in testing, living with hepatitis C, and then in treatment. So next slide. So we think previously, as we talked about, hepatitis C used to be a baby boomer disease. So blood banks began screening in 1990. It became widespread in about 1992. However, now it's used as a marker for injecting drug use, particularly for young adults. And the opioid crisis fueled an increase in the number of new hepatitis C infection. So we think about this in stigma as a baby boomer disease related to unscreened blood products Hepatitis C was external. It is something that happened to a person. Now, with blood products being screened, hepatitis C is seen as something the person does that gets a disease. And that's a very different shift, particularly when we're looking at behaviors such as substance use, specifically injecting drug use, because there's a stigma there and it confounds the stigma related with hepatitis C. Next slide, please. So testing. So you'll see that the kind of overlay of stigma related to the disease itself, testing and living and treatment for hepatitis C. So that is actually a reason many people avoid getting tested, is that perception of wondering how people will think of them. And studies show that up to 95% of people with hepatitis C say they've experienced stigma at one time. So there's stigma around hepatitis C, but also about substance use disorder or persons with history of incarceration. So this intersects the disease-related stigma and then marginalized patient identities. So we have those two factors overlapping that leads to poor health outcomes and exacerbates health disparities. So we're not even getting the people tested at times. Next slide, please. I did some research about stigma and living with hepatitis C. So this is a cross-sectional study among patients who have had hepatitis C, and it's a good sample size, about 300 folks at outpatient clinics in Philadelphia. So 2018 and 2019. So these are folks who are living with hepatitis C and the receiving care for it. There were some factors associated with significantly increased reported stigma. Previous treatment without a cure, higher level of hepatitis C related knowledge, female, gender, Hispanic or Latinx ethnicity, some college education. Now, annual income that was lower, between 10,000 and 40,000, was associated with significantly lower stigma scores. So this was surprising to the researchers. So a lot of stigmatized populations, it was a barrier to testing. But then we looked at folks who were in treatment and saw it was associated with increased stigma. Next slide, please. So they suggested some reasons that a deeper understanding of the virus could lead to feeling more stigma. That seemed a little counterintuitive to the researchers. However, they thought when they looked into this, knowing more about the virus could also mean knowing more about the stereotypes and stigma, leaving people aware when they're perceived this way. And then that fear of stigma leads people to keep their diagnosis secret, and that eliminates possibility for support. So it's self-perpetuating, the self-stigma, and then not sharing because of that stigma. And then also fear of transmission to loved ones or disease complications can cause internalized stigma or shame. Next slide. So even looking at people in hepatitis C, care or living with hepatitis C, stigma affects hepatitis C treatment. So providers can be seen as gatekeepers and leave patients feeling judged. So that's part of the stigma with treatment, is that folks feel judged and that they can't receive treatment unless the provider says it's okay. So in our needs assessment, we talked about earlier, interviewed folks with lived experience with hepatitis C. So these are folks who had hepatitis C, and some reported that there was an assumption when you sought health care that maybe they were doing drugs or had hepatitis C, and you can feel judged. However, some providers are also very good. And then the belief of providers that you need to have sustained sobriety, and that's not a recommendation. And Medicaid in Montana removed that as a requirement. So the provider wants you to stop using until they're cured. They just don't want people to get reinfected. And so people can feel, like I said, very judged for that, and it can delay treatment. Next slide. So how do we address stigma? So in addition to treating the virus with medication, healthcare professionals need to treat the person using a psychosocial approach. So really, we can't test our way out to eliminate hepatitis C, and then treatment can be challenging due to the stigma with hepatitis C. So it's important to create a safe and positive health environment. And that can include avoiding assumptions about how a person may get infected, non-judgmental language. We talk about person with hepatitis C rather than a hepatitis C case. Avoid stigmatizing terms and stereotypes. Maybe saying a person with a substance use disorder rather than an addict. Consider that people may have recovered from their addiction rather than calling folks just all injecting drug users, whether it's past, present. And then it's important to educate people diagnosed with the virus about treatment and transmission. But this isn't just a checklist of here's hepatitis C, this is the risks. And that can eliminate misconceptions. But to address that self-stigma or people with the virus, exploring their personal beliefs is very important. And then establishing that support. Next slide. And I think education also goes beyond the patient and providers. Really is for all healthcare staff. Some folks with hepatitis C felt like not just healthcare staff, but even front desk staff or medical assistant staff treated them differently because of fear of hepatitis C. Also chatting with family members about how it is and isn't transmitted, communities, and workplaces or schools. So folks should not be included from work, school, play, childcare, other settings because they have hepatitis C. There's no evidence that folks can get hepatitis C from food handlers or teachers, service providers without blood-to-blood contact. So even now, there is a lot of education that we can provide about how hepatitis C is and isn't transmitted. Next slide. So some resources that we can provide. There's some major guidelines from CDC about hepatitis C screening, testing, clinical management. The last resources I really like, questions and answers for the public and questions and answers from for healthcare professionals. And these are from CDC, but it's put forth in a very nice and accessible manner. Next slide. It is Hepatitis Awareness Month. So I have a QR code that brings you to some resources, some social media, flyers, infographics that can be used for Hepatitis Awareness Month. Next slide. Okay, that comes to the end of my content, and I'm happy to take any questions that may have come up in the chat. I'll let you know how you want to handle it if folks want to come off mute.
I'm not seeing any questions in chat, but if you have a question, if you want to jot it in chat or come off mute. Anybody have any questions for Helen? Helen, I have one question that we talked about earlier. So in our other states, are folks expecting a counterpart like a Helen McCaffrey in, say, Alaska or Hawaii, or Wyoming?
Yes, that's a great question. And that's correct. So each state has a hepatitis C program in various sizes. It is a required reportable condition to CDC. So there would be, like I said, depending on resources and number of cases, someone like me or a hepatitis C program officer and epidemiologist in each state. There also has been additional funding for states to develop viral hepatitis elimination plans. And you may have seen I talked a lot about hepatitis C during the presentation, and really that's just because of where the burden of hepatitis is in our state. And that's what's seen nationwide as well. One thing also states have developed, and we're happy to have here, is a cluster detection and response plan. So we have that for viral hepatitis as well as HIV, of how we deal with outbreaks. Sometimes we see them in settings such as correctional facilities, where you can have folks through risk behaviors develop or acquire hepatitis C in those facilities.
Well, thank you so much, Helen. This has been great information. And we do have one question that popped up. I don't know if you can see the chat or not, Helen. Denise is asking, what precautions should nursing homes take into consideration when a resident or patient has active Hep C?
Okay. So, and what I'm thinking we mean by active hepatitis C is that they're currently infected, right? They haven't been treated and they haven't cleared the infection. Really, it's just basic bloodborne precautions. So it comes down to that. Just whatever you would do for those precautions will also, you would take into consideration with somebody who has hepatitis C. And I see another comment, dedicated glucometer if on auto checks, AccuChecks. And I'm not familiar with that in this context. Is this something that could transmit infection?
Maria, did you want to come off mute and expand on that, or did you have a specific, or just making a comment?
Yeah, I just wanted to, anytime there's a bloodborne pathogen, right? They have, if they're getting AccuChecks, they have to have their own dedicated glucometer. It can't be shared with other residents.
Okay.
Okay.
Great, thank you. What's interesting about hepatitis C is that it can be transmitted in areas you might not think about. Tattooing, unregulated tattooing, certainly. But there was an outbreak related to, you may know about this, to cupping, which is where you heat kind of a cylinder cup, and it's to relieve a lot of times inflammation. But folks weren't sterilizing them from patient to patient. It can cause micro cuts in the skin and tiny amounts of blood. And they did find that associated with hepatitis C. And as an epidemiologist, I found that very interesting to see that as a transmission risk.
All right, I'm not seeing any other questions. So I know that Mary has the link in chat to that evaluation. So please complete that for today's session. And thanks again to Denise and Maria for their added questions and comments. And thanks for everyone for joining today, and appreciate you, Helen.
Oh, thank you very much. I very much appreciate this time to share some information.
All right. So until next week, thanks everyone who was on today. Have a great
Thank you.
week.
Bye-bye.
Bye-bye.